شكرا للدعوة الكريمة دي والنهاردة هنتكلم عن حاجة somehow sensitive. You may have some personal um, take on some of these things we're gonna discuss today. Again, it's not um, black and white. It's not 100% measurable, but we'll try to share some experience of what we do here in Australia. Hopefully, you can basically adopt something. You can learn something. You can add to us, show us some other perspective. So again, uh, it's going to be starting with some concepts, but we will not drag into theory and evidence. We'll try to make it more practical. I'll At the end, I'll give two true cases that I've seen lately, probably in the last 6 months, just to give some context. And again, I always say simple is genius. So if any protocol or guideline that is complicated means it's not applicable and it's not useful. So I'll try to be as simple as possible. Again, as lifesavers, we basically we look at death as enemy, and we sometimes consider it as a sign of failure. We are afraid of being negligent, afraid of litigation. That's why we always try to prevent death at all cost sometimes. And our job is somehow is more about resuscitation. But actually, as you all know, death sometimes is quite a natural process and in many cases inevitable. And the question is, are we good at dealing with death? And at what stage we need to change our care from treating the disease to dealing with death. So I'll go back to this very iconic kind of graph that you will see it in any resource tackling the what they call it, the palliative care or end of life. So this graph is showing the trajectory of diseases. So we'll start with the sudden decline from acute illness, this sky blue dotted line. That's um, that's the scariest scenario we see. We see a patient comes with after trauma or with overwhelming sepsis, and you can see that quickly the function deteriorate with the normal function, it acutely becomes quite incapacitated, and death is imminent in few hours. So that's a very usually um, tragic kind of scenario. Cancer, goes slightly decrease the function, and then again in few months, after years of fighting cancer, they deteriorate their function, and then and sometimes as an intensivist or emergency doctor, you see them at this end of their story. The organ failure is a scenario that is somehow different in a way that it's the function of like liver disease, cardiac, COPD patient. Usually they come with this kind of oscillating function up and down. But as you can see, with every exacerbation of this chronic disease, they usually, even after they recover in your hospital, they never go back to the usual function. They will be like steady, slow decrease of function. And again, you will find them at the end of their at the end of their at the end of their journey. And again, you need to decide: are we going to be doing much for this patient? We can't regain what already lost. With frailty and dementia, like elderly patients, the you can see the again has the same trajectory oscillating from up and down. but maybe the function start as a low at a lower level. But again, you have the same problem. You got an elderly patient, dementia. Every time they come to your hospital, they after an episode of whatever UTI, sepsis, pneumonia, they get for example, another stroke. Again, they never go back to the usual function, and again they deteriorate slowly. And at a stage, you need to know that you can't make miracle out of this presentation. With the chronic disease also, you have this graph also tells you before the start, like the diagnosis, you have this phase that you're trying to prevent the disease from happening. But then once the diagnosis happens, you have the curative phase. You try to do your best to treat the patient. They go into this chronicity. And as the time progresses, you find that the curative care you're giving is getting less effective, and then you start giving more symptomatic treatment to the extent that at some stage, actually, most of your treatment is actually symptomatic, and you can't do much for this disease process. Even after some stage, then the what's called end of life um, care phase, that actually you need to diagnose this, and because this phase is actually you need to diagnose that this patient is actively dying, and you need to provide even some sort of even more different kind of care, because at that stage the needs are not about even symptoms, probably about spiritual. It's about support to the patient, help the patient go through the symptoms of death. And then again, our care in hospital is not just about the patient. It's after death. There is a family that might be like going through you know um, like sadness and loss financially or socially, and you need to provide support and make sure you're not creating another patient. So again, as you can see, the disease, we need to be realistic. We need to at earlier at the disease process, you provide some care. At the as you approach the end, you need to start about thinking about palliative, symptomatic, and other type of care. So you need to be who will decide this? Who is it only it's the responsibility of the patient? Is it the treating physician? Look, it's sometimes difficult. Sometimes you get a patient in your department and you don't know the story, and you think that this patient is actually not benefiting from your care that you can provide in ICU, and then you need to make like the harsh decision. But is it um, one doctor decision? So again, these are some guidelines we use. Again, I'm trying to make it more like simple and applicable as possible. So that's what we teach our juniors, that, okay, this is somehow a difficult decision. Try to get seniors involved, and um, stakeholders, doctors who cared for this patient before, treating physicians, treating surgeons, and then you can actually, if you're a senior, you can make this decision. But maybe if you're in doubt, which not in every case, some cases you just make a decision. This patient, I'm not admitting to the ICU. I'm not basically even in ED. I'm not starting resuscitation efforts. If you think it's in doubt, you can get a second opinion. And in some cases where you have the time, like cancer patients or even complex patients, you can have MDT to decide. Okay, so you get a consensus from your team, that we're happy that this patient probably approaching the phase that we need to think about palliation. And second element of how you collect data about the patient and make a decision is to ask about the functional history, which is very important. So we used to ask about the symptomatology of I mean, what patient is coming from by, and what kind of signs, vital signs, examination, medications. But sometimes we miss this very important cardinal component of the history, which is the functional history, the cognitive function, whether it's estimated by a geriatrician, what kind of communication with the family. That tells you about what phase the patient is in at that journey, mobility, fatigue level. And this should be documented and like estimated and documented in your notes. Then you can basically extrapolate from this data like an idea about whether this patient will tolerate any advanced kind of care you're going to give. So again, dependence, toileting, showering, feeding, driving, shopping, all these are very important. It's not non-medical. It's actually medical history that you need to know about your patient. Incontinence, mental health, and again, previous level of function. If you have someone who's like highly functioning most of their life, very proud to be like a very dominant figure, sport, going around and all this, you need to know this because you know that those patients will be probably not happy with the level of function they are in, and maybe they don't want like life prolonging measures. Again, you should not assume. So case by case, you need to ask about the function, about the previous function, and the what's more important is the patient wishes, whether they are able to express this, whether they want to go through difficult treatment or not, and if the patient is basically lost capacity, lost ability to communicate these wishes. Again, in many countries, including Australia, we have this advanced care directive. Usually, patients, as they become old or as they become through, the chronic disease, at some stage, whether the treating doctor or the general practitioner, like family physician, at some stage we'll get this document to collect some wishes from the patient. And again, this is a true case that, only yesterday I took this photo. So you get this patient in the ED from the nursing home with this document, whether they want, for example, if you can see here, whether they want CPR or not, whether they want life sustaining measures, which, they want here, for example, this patient didn't want sustaining measures, including like intubation, mechanical ventilation, but actually they're happy for some intravenous fluids, antibiotics, and but probably not blood transfusion. So again, as you know, this will be a very helpful means to tell you the wishes of the patient as they lose their capacity to tell you. Then this is documented in advance to tell you, some guidance about the care. So again, you got consensus or feeling from the treating team. You got social history and functional history, wishes from the patient, and then you get the patient plus or minus family into a meeting, usually in a time that is suitable for the family. You bring them, and you start now trying to have this two-way communication session and mainly listening first. So first will be listening before you start breaking bad news, and try to get their insight about the situation. Are they still thinking that we need to do everything? Whether they have already decided in advance. So every family is different. Every individual is different. And then you try to get the pieces of the puzzle together. And again, this can be either consolidating your idea about the situation, like, or maybe, in this meeting, you find something significantly different from what you already thought. And then the fourth phase, then now you start, you know, telling them what you think honestly, without any judgmental kind of one-way directional kind of imposing something or coercive kind of your agenda on anyone. So you just think, okay, I'm telling you that's the fact now. We think with this function, with this prognosis, with this stage of the disease, we think we should be doing this. What do you think? And again, this communication is should be done by a senior or like a senior registrar at least. And then you give them the show them the options and why you're choosing these options. And again, usually here, that's the ceiling of care in Australia is called again, different jurisdictions have different like governorates, like in Egypt. We have different states here, so different. So the terminology will be different. But in New South Wales, where Sydney is, we call it resuscitation plan, and that's the form we use in our hospital. So this is you get the patient name, a sticker here, and if you can see you get here whether the patient what do they think about pharyngeal suction, oxygen, non-invasive ventilation, intubation, a referral to ICU, yes or no, any non-urgent interventions appropriate or not, like major surgery, so on. So you can write here, and then here is more it has to be highlighted like CPR or no CPR. That's important because in mid call, which is like when the team rushes to the patient in the ward, whether they find CPR or no CPR. So again, this document again is the you write there what and as you can see, it's not about CPR or no CPR or intubation or no intubation. It's like there's a spectrum of things that you can offer to your patient. And again, vasopressors, yes or no, you can write it down. Okay, but I'm sure you will be asking, I mean, what if the patient or the family decide to have everything, or if you offer something and they don't want anything of what you think is appropriate. So this is we call it conflict. So this is a conflict. You should be avoiding conflict. You should be hopefully the journey of the patient throughout the health system. Hopefully they found other reasonable doctors telling them the prognosis, whether there is hope or no hope. But again, this happens very rarely, but it still happens. And um, there are some ways to avoid this conflict. Number one is, which is most important way to avoid conflict, is that I'm putting this photo of like a restaurant and someone is speaking from a menu. So this is not a menu. So you don't come with this form to the patient or the family and tell them we have this. What do you think is it's the autonomy the autonomy of the patient doesn't mean they choose and pick and choose what they think, because we are the gatekeepers, and I've written it here like we are the gatekeepers. We are paid because we are trusted with this kind of technology, whatever technology, in ICU, in emergency. We are trusted people, and we're well paid to um, you know empowered by the community to help the patient. So we are the gatekeepers for this. So we tell them we are not actually offering this and that. And we think we have we have these options we can give you. And if they say, if they agree, and in most cases they agree. If they don't agree, then that's conflict. You can you can allow some time. They might tell them, okay, that's okay. We will reconsider this after 24 hours. We have another discussion with you, but that's what we think. Or you can offer like a second opinion. Let's get the ICU people as an emergency. I tell you, okay, I think you should not go to the ICU, but we will get the ICU. And we tell them in the ICU, they come as a second opinion that usually resolves the situation. Again, the ethics of the patient autonomy is that the patient can refuse treatment. And that has been the major shift in the concept of autonomy in the last 10 years or so, is that patient has the right to refuse, but they cannot demand it. They cannot force it on a doctor that they think this is unethical treatment, for example. And I'll tell you another example. Can a patient anywhere in the world go to a cardiothoracic surgeon and tell them, look, I have a heart failure. Please change the mitral and also the aorta. I think let's give it a go. I know I'm dying, anyway. So can you do this for us? And it may help. And the cardiothoracic surgeon would say, no, you can't force me. Likewise, in ICU, you can't, because you are the expert in this industry. They can't come and say, but I'm a terminal cancer. Just give me ventilator. Maybe a miracle will happen. Maybe I will just get cured. And just do what you know, some oxygen, maybe some ventilator, give me, because that's, you save lives. So again, if the cardiothoracic surgeon thinks it's unethical to do any surgery for anyone is asking because the evidence is against this, also the ICU doctor or the emergency doctor also empowered to say, I don't think it's ethical. You can't force me to do this. And that's a major shift in the space of patient autonomy. So the other ethics, the cardinal ethics of healthcare, which is uh, autonomy, do no harm, do good. Again, anything in medicine, if number one, if the balance between the benefit and the risk is towards the risk and no much benefit, then it's unethical. Again, you put a patient in ICU with no benefit, causing harm with an anxiety, pain with the endotracheal lines everywhere, an anxiety, financial loss with no benefit, then it's unethical in medicine. Like anything else we do in medicine, it has to be more benefit than harm. And this ethics of healthcare will help you also empower you to say no when it's appropriate to say no. Like with justice, we have in everywhere in around the world, we have limited resources, limited beds, and we have to give it to the one will benefit the most. You can't just waste resources, and we are empowered by the community, paid by the community to look after their resources, the taxpayer money. So you can't just waste it. So ethically, very ethically to say no to the patient if you don't think it's ethical to give this treatment or the other. I'll give you some examples of ceiling of care. That's made up examples before I go to the two cases. If 61-year-old with very advanced end stage COPD, already on home oxygen, 24 hours a day, still cognitively fine, but he's like on oxygen. Sometimes even takes oxygen off and sneak and have some cigarettes. Wheelchair mobility because of his dyspnea level, and recurrent hospital admissions. Every few months he comes with the exacerbation. What ceiling of care I would be giving for this patient? Look, in my department, I would never, although he's 61, I would never intubate this patient if he comes with severe COPD. He will not be weaned easily. He's at the end of the journey. I will offer him, though, because of his age, I'll give, and because of his cognition, he's still normal. I'll give him an NIV, maximum bronchotherapy, antibiotics. I admit to maybe HDU, maybe ICU if I don't have HDU, which is HDU is high dependence, which is lower level. And if he arrests, I will never do CPR on him. I wish I can do if it's possible, we can put this to the floor, this example. If someone wants to give suggestions for the second case, 32-year-old advanced metastatic ovarian cancer with pleural effusion, let's say peritoneal deposits, and also malignant ascites. Now on palliative chemotherapy after failed all the curative chemotherapy, and she's 32, coming with, let's say, respiratory failure, like hypoxia, but still okay on oxygen. What you gonna do as a ceiling of care if someone wants to suggest anything? She's 32, she has a young family, three kids, but again, she's been fighting this for 2 years already and presented to you with a bit of hypoxia, a bit of hypotension, and malignant ascites, pleural effusion. What are you gonna do? Again, there's no right or wrong answer. Will you tube this patient if she has turned out to be like in severe sepsis and severe pneumonia? Will you tube this patient? I tell you what we're gonna do here in Australia. She will be having, with the hypotension, she will be having, treatment for sepsis, antibiotics, albumin. She will have a pleural tap, maybe tapping some ascites. But if she arrests, she will not have CPR. She will never be intubated. Um, Probably not going to ICU. Should be ward based, like in the ward, but not in the ICU. And I will have these interventions. I'll still do tabbing. I'll give albumin antibiotics. But if she arrests, I'll be fully palliating her. Or like deteriorating fast, I would be palliating her with morphine. Get the family around. Put her in a single room, unlimited visitation time, so everyone can around the clock they can come and visit, and in a quiet, nice room. And it's sad, but again, we're not gods. We can't fix this scenario, so we basically look at the patient as a whole and give them a good death, because their needs now is not curative. 77-year-old dementia patient, and had ischemic heart, multiple CVAs, bed bound completely, and severe dementia, and recurrent aspirations, and worsening renal function lately, and presented with another aspiration, hypoxia. This patient, even though they're hypoxic, they may get some oxygen. If we can think about antibiotics for 1 or 2 days, but if not responding, we will be fully palliating, no intubation for this recurrent aspiration, and no ET tube for suction. And again, get the family around, ask about what their wishes in the end of life, whether they want the priest to come and any spiritual kind of needs, and get the family around. And we tell them early on that his patient possibly either this admission or the next admission will die and will not go to ICU definitely. So again, I'm giving you the perspective, and think about what things you can adopt from all these stories, or things that you can modify to make it work for you, or maybe give suggestions to me as well. So these are the answers. And again, worsening renal function, I don't care. If the creatinine is rising 10 times the normal, I will not offer dialysis for this dementia patient with pneumonia aspiration. I'll just give fluids, antibiotics for a few days. And again, I write documentation is very important. You document all this, why you think so. And if you're in doubt, speak to your friend, other, team member, and make sure you're the consensus, and even a nurse. So the input is not from only doctors, also nurses, experienced nurses, are a very big asset in your department. Now, I'll get quickly two cases. How much time I have? Sorry, I'll try to go through this as quickly. They are real cases, happened in the last 6 months or so. Again, I had this patient, 69-year-old female, came. We had an ambulance care, ambulance bat call, or like a pre-arrival call that they bring it.
Dr. Ayman, you have 15 minutes. 15
15
minutes.
minutes. Okay.
No,
Okay.
no problem.
Okay. So again, she came with cardiac arrest. And the story found by husband, in bed by husband, unresponsive, started CPR, called the ambulance. Ambulance came, gave one cycle of CPR with one adrenaline, and had ROSC just before arrival to the ED. History. Only history for this 69 is that a week ago she had some shortness of breath, and GP started some salbutamol, but otherwise her past history is nothing much, like a bit of hypertension, hypercholesterolemia, generally well, no mental health issues. And actually, during the CPR, the husband actually noticed this fungating mass in the left breast that he didn't know about it previously. And he was like quite shocked while he was doing the CPR before the ambulance arrived. So examination, so was an LMA, the ambulance LMA, a bit like significantly hypoxic, ETT, like the the LMA capnography is very high as well. Anyway, diffusely blood pressure is dropping after the adrenaline, GCS still 3, and hypothermic. So, and this fungating mass left breast quite smelly and infected. And that's quite unusual for a white lady to come, and no one knows the diagnosis about. And POCUS, there was a, large RV with septal bowing, and IVC was quite dilated. Again, it's ventilated patient. She's obese a bit, but again, we thought like, okay, what's going on with this left breast? Is it PE? Again, this shows this is a venous gas. So just look at the lactate here. Lactate is very high. Sodium is 150. Potassium is low. That's for someone like was well in the last few days, just a bit of salbutamol. But base excess is minus 13. CO2 is very high. So yeah, anyway. So impression was, is it so cardiac arrest? Why this happened in this apparently previously healthy lady? Undifferentiated shock. Is it PE? Is it sepsis from the fungating infected mass? Is it PE again with this hypoxia? Is it that's a copy paste from the notes? Is it pneumonia? Is it metastatic, with metastasis to the lung with this hypoxia? And again, these are the differentials. Always write differentials. Plan. Okay, so now we know someone. We're not sure. Is it something reversible? Now she's ROSC already. We managed to get her back, and she's relatively young, 69, no previous chronic disease. Functionally, she was fine until a few weeks back. So we decided, okay, maybe just PE from this. Let's tube the patient. and start adrenaline, noradrenaline, still blood pressure is still dropping, and give antibiotics. And the plan was blood pressure didn't manage to bring her after all this. So we decided before we do the CT scan to give thrombolysis for this PE, and based on the being vulnerable for PE with this mass and um, this RV dilatation. And the plan was to do, once the BP is stable, to do imaging, like full body imaging, including pulmonary angiogram, which basically we managed at some stage to stabilize the patient, maybe after 1 hour or so. And the CTPA was negative for PE. And actually the left breast mass was locally invasive to the chest wall, lymphadenopathy, also lung mets and skeletal mets, bilateral pleural effusion, very advanced cancer. CT brain is normal. Fortunately, we didn't cause intracerebral bleed from this thrombolysis. And actually, abdomen and pelvis, no mets or anything. But again, the very locally invasive and metastatic cancer. So what are you going to do? So just think, you have a patient who's actually on maximum or like a significant doses of adrenaline or ad, had fluid resus, had thrombolysis, and now we know her prognosis is very bad. So sorry for this. This is again copy paste from the my notes. So again, discussion with the family is very important. So discuss with the husband. Apparently, fairly independent. No advanced care directive. She didn't write anything, and never revealed any concern about breast mass. And the husband unaware of seeing a doctor for the same, and definitely no chemotherapy or any intervention happened for this. Again, here we told them husband is made aware, unlikely curable curable cancer. So we know from evidence that this cancer will, and again, this happened after cardiac arrest and some brain hypoxia, and so likely added brain damage. So unlikely she will make recovery back to her baseline. So you have to, so at that stage, we have to tell them the truth after some empathy. And so basically, we did this we call it the family room, preemptive. So usually they know that there's something wrong coming, and we get a social worker, we get a nurse. So it has to, breaking bad news should be like a gentle, but at the same time, we need to tell them the truth and be transparent. And again, even if she survives this, no oncologist will give them cancer treatment. And again, here is the husband said, like, prefers to leave the decision about further resuscitation to the medical team. Thank you. At least we managed to get a negotiation to the target to target ceiling of care. So we advocated full palliation, including extubation. The other alternative was another doctor was saying, let's get this patient to the ICU, and the ICU, we are in the emergency, right? So send to the ICU, ICU extubate. So I managed to go even further and say, like, we extubate here because we didn't have an ICU bed in our hospital. We had to send to another hospital. So much use of resources for a futile case. So we can do extubation here. And I managed to convince my team and hence also managed to convince the family. So the family asked to wait until daughter arrives before withdrawing mechanical ventilation and extubation. We are happy to accommodate, and that's my documentation. We are happy to accommodate family request. Not for CPR if arrested meanwhile, if arrest before the daughter comes, we will not resuscitate, because again, in the CT scan, there are so many fractured ribs from this skeletal metastasis, and it's unethical to do another CPR. Another family meeting, when the daughter arrives, came also other family members. Again, we told them the same um, prognosis, and we had the agreement on just full palliation. So we give morphine, midazolam. I think we gave it subcut, yeah. And fentanyl was ongoing anyway with its suction extubation. We monitor something else. We monitor the not the oxygen or blood pressure, heart rate. We monitor, and we need the nurse knows that we need to monitor an anxiety secretion, like bothering secretions in the airway. Again, comfortable, slow breathing post extubation, and after some time, she basically became apneic, and death is declared. And certificate was issued, and cause of death was advanced metastatic breast cancer. And may her soul rest in peace. So, reflecting on this case, it's a very late in the disease. She already arrested, and again, patient probably. This is very important. So, patient probably had an insight about the nature of the disease, and she chose not to seek medical treatment. So that's respect the patient. She didn't have mental health or cognitive impairment, but she didn't go. She knew probably that it's a cancer. It doesn't come in one or 2 weeks. It comes like at least this advanced cancer probably is going on for months, and she chose not to, and she chose her life to end like this. We respected that. I was happy that we accommodated her wishes, and we didn't give her any futile, painful treatment, and we didn't give the family any false hopes. Case two, quickly. Another case, 75-year-old who basically, again, a pre-arrival ambulance that 75 had an overdose of Valium, and she GCS is 4, and she's hypoxic on oxygen. When she came, we knew straight away that she had severe rheumatoid arthritis. She's bedbound for probably 2 years, wheelchair bound as well. And again, after the ambulance arrived here, told us that they found suicide note with empty boxes of Valium, 5 milligram, probably 20 tablets of 5 milligram Valium, which is the diazepam. Husband then requested not to treat her, and asked the ambulance to leave the patient in like not taking her to hospital out of respect to her wishes to die. And she had actually advanced care directive and was present with the ambulance, that she doesn't want to be resuscitated. But ambulance still insisted to bring her because there's a mental health act. So because of suicide, they have to act. They have to bring the patient here, which I totally agree. Past history compared to the first case, like extensive. Like even rheumatoid arthritis was the major thing. Also a stroke. She had surgical things for her rheumatoid and osteoarthritis. And as you can see, she's on significant and compliant to her medication. So someone is different. She trusts the health system. She was with the health system for years, and she was compliant. And the good thing is she didn't overdose any of those things, because some other medication might be painful death if she tries to suicide with these medications. Physical exam, she was patent airway, but hypoxic on oxygen. She's shallow breather because of the Valium. GCS was 4, which is probably a trigger to tube a patient with toxicology like this in other patient. But again, looking at her, she was febrile also. Turned out to be having flu as well. Probably the flu caused her rheumatoid flare, and then she decided to make this decision. She's underweight, very, very small lady, and cachectic as well. And And that's her X-ray. As you can see, the bad rheumatoid. She had surgeries. She's kyphotic. Again, in the resus, the first thing we can do is a venous gas quickly, and she CO2 was fine. So she's not, there's no, you know, need to do something drastic quickly. ECG was sinus tachy. We had a mobile X-ray. We sent some bloods. Eventually, nothing major in her bloods, and CRP was high, for 70, probably from the flu, and paracetamol level, which is a usual, way to overdose in Australia, was normal. So she didn't overdose any of her medications. And her Webster pack, which is the where the medication is, it's actually full. So she didn't. We know that she didn't overdose. So we know it's a single agent overdose, Valium, and it's suicidal. And again, very poor background function. That's more important than tell me the diagnosis, tell me the function of this patient. She's bedbound, she's miserable. She is on medication, like writing in her advanced care directive that she has intolerable pain daily, and she doesn't want to be resuscitated. But we have a problem now. We have to treat the overdose. So consensus with the ED, initially we were like actually pre-arrival, we had the airway doctor wait like ready for intubation, but we stopped that straight away. And let's give some flumazenil antidote. And actually GCS improved to probably 13, 14, but still not competent to make any decisions. And we know it's flumazenil is very short acting. And again, we didn't give charcoal because of potential aspiration. And now husband is actually doesn't want any advocating for not to treat and describing long-standing suffering with pain and actually telling that retrospectively he actually now understands why in the preceding weeks she started saying goodbye to people and basically giving her things to friends and stuff. So she was giving her stuff and saying goodbye to people. So he and again, what's more significant, that she was actually exploring something called voluntary assisting dying, which is euthanasia. So she's very adamant that this is different. Euthanasia is different from what we are talking about today, basically. Palliative care is not a voluntary assisted dying. You choose one day to go to a doctor and tell them, I want to die that day. And then you get a psychological assessment and not depressed and not suicidal. And because you have a life limiting disease and your life expectancy is less than a year, then you can have, and this is not everyone signed on. For example, I didn't sign for this the voluntary assisted dying. I still feel it's unethical. And if someone comes to me and asking for this, I would usually say, okay, I can assist you to see these services, but I'm not doing it. I don't believe in it, especially since we have a very good palliative care service in Australia. Anyway, again, what I responded is saying, again, we made it clear that under the Duty of Care and Mental Health Act, overdose should be treated. Voluntary assisted dying process not finalized, hence irrelevant. So we can't now do the voluntary assisted dying because now she lost capacity. We're not going through this, and it's not finalized. Didn't go through the process with the psychological assessment and all this. It takes time. And agreement with the husband that, okay, ceiling of care would be negotiation, that's important, that you have to compromise on something. So, okay, we give antidote and fluid and oxygen, but not to be invasive or send to ICU or intubate this patient. I spoke to the poison center. Again, it's something I don't see every day. The cases, these two cases I'm presenting because we don't see usually those cases. So I want another doctor to basically support me. So a toxicologist, usually they are either ICU senior ICU doctor or ICU or emergency doctor. Again, agreed that we should not intubate. Let's give flumazenil infusion, which we usually don't do usually. It's and you just made up some dose and keep overnight. And in the morning, usually by then, usually the benzodiazepine is uh, toxicology is gone, the effect is gone, and then the reassess. So discuss with the general medical, like a medical doctor, not the ICU. Again, another expert agreed to this, and we admitted to acute medical unit, which is it's like a HDU or less than HDU, so not for ICU. And we know that we'll not tube at any stage, and treated reversible factor, and we gave augmentin for this fever after some septic workup, and Tamiflu because she can't swallow, so having given. And if she survives this, will be mental health review. Progress in the AMAO, she had flumazenil for 24 hours. GCS was good. She was rousable, still spiking temperature, and she become more and more hypoxic. So now we cover 24 hours of flumazenil or like at least 18 hours. And again, this is a copy paste from the family meeting in AMAO. And that's not me, that's in the ward. So that's the document. Now, patient is past benzodiazepine overdose effect. Now, flu A complications. Previous wishes from patient is clearly not to active manage the acute curative treatment. Decision to cease augmentin. Full palliation, including subcutaneous morphine, hyoscine to clear the secretions from the airway and monitor a sign of distress. Within another 48 hours, she passed away, and the coroner, which is like everyone would be afraid of coroner case. Usually they investigate any death. So eventually agreed later on, I found it in the notes that this patient died of natural cause as a complication of flu and significant comorbidities, not primarily suicidal. So that's for medical legal reasons, and also for any if she has any insurance or anything like that. So she didn't die from suicide. Reflection. I'm happy that we respected her autonomy. She had a good, non-painful death eventually. Voluntary assisted dying or euthanasia is controversial, and I didn't sign for, but sealing of care and palliation are not. So they're not, I can still do this, and it's some good compromise. And being non-judgmental, reflecting on this case, like she I won't judge her why she chose to die like this. I mean, we are not here. We come treat the patient, and we are not judges. So take home messages quickly. Again, both palliation and end of life care are integral part of healthcare. So they are not they are actually part of the treatment for the patient. It's just a different type and sometimes more ethical, more important to the patient at some stage of their disease. And it's not, if you give curative treatment in a dying patient, it's just definitely unethical. And again, this kind of care and this kind of thinking should be part of the medical and nursing training curriculum. And it's not just the palliative care consultant. Um, it's not the palliative care consultant job to do all this for your patient. You can get consultation from them. You can get help from the palliative care team, but it's also it's at the end of the day, this is your patient. So you need to know these skills and be comfortable asking the difficult decisions. Governance of end of life and palliation should be under the normal health guideline policies and standards, not under new laws. So we should not wait for new laws uh, to uh, to regulate this, because it's part of the normal ethics. We should not need laws. With practice and consensus, the more we do this, we become the end of life care will become less controversial. Again, we're not talking about brain death, um, like a sorry, I'm hearing my there's echo. Anyway, when brain death, for example, is controversial. The definition of brain death. Euthanasia is controversial. Organ donation is controversial. But end of life care, palliation is something should not be under new laws. Always consider and advocate for patient best interest, even if unable to express. Just think about, okay, if the patient is in the room now, how they gonna behave, how they gonna choose. And again, this is by speaking to the family, and you ask them directly, what are the wishes, how they gonna. And again, in this scenario, usually it's you either get it directly, or also think about, if I am as a doctor in this scenario, after knowing this patient, how they live their life, is it going to be acceptable or not? And again, this is also in from our culture, all right? So it shouldn't be controversial. And this is last slide. This is an Indian guidelines for end of life care policy. And I choose this if someone wants to read more about countries who are going through similar challenges um, from thinking of healthcare as saving lives into this holistic kind of approach, which is how to change the goals of care as we go into chronic disease. So they have the same challenges as in any other developing or other similar health systems. So it can help anyone wants to pursue this career palliation of patients in the ICU or emergency. And
Thank
thank you
you
very
very
much.
much, Dr. Ayman. Very illustrative, but most of it cannot be applied in Egypt. لكن احنا يعني already بنعمل كده، وبنقول للنواب من غير ما نكتب ان this case for not CPR او يعني معظمهم ما بيسمعوش كلام ويحطوا كميات هائلة من نور ادرينالين لعيان داينج ومالتيبل ميتاستاسيس وعلى فنتليتور. فانا مبسوط من كلمه نوت كيوراتيف تريتمنت فور اند ستيج بيشنت. في سؤال على الشات، يا ريت تجاوب عليه.
طب يا ريت، انا بس عشان انا مش عندنا مش عارف ازاي حاجه، ممكن تقرا لي ان انا مش عارف اجيبه تاني، لان لحظه
بيقول
كده.
امس دكتور محمد هشام ممكن تسال. بيقوم انا شايف problem the cure would be based on physician and patient point of view. No solid guideline would make different decision for same patient.
تاني كده، لان انا الايكو كان مش مخليني اسمع تاني كده.
A problem that cure would be based on physicians and patient point of view. No solid guidelines would make different decision for same patient. How Islam approach this dilemma?
how اسلام الدين الاسلامي، مش كده؟
How
اه
Islam.
اوكي. والله انا طبعا انا يعني احيي كل الموجودين سواء مسلمين او غير مسلمين. الكالتشر يعني في يعني الدول الشرقية كلها شبه بعض جدا. المفروض ان لما يتعمل كونسنسس زي ما قلنا كده، ان هو خلاص اتفقنا ان احنا عملنا اللي هي الريسستيشن بلان دي، وبتتحط في الفايل او بتتحط على الكمبيوتر في الفايل بتاع الكمبيوتر، على الكمبيوتر بتاع العيان. المفروض يحترم تماما. واي حد يعمل حاجه غير كده، سواء نيرس الدكتور يغير الريسيشن بلان دي، الا لو اللي عاوز يعترض بيجي يقول لنا ان انا شايف ان هو، وده حصل نادر جدا، يمكن من اخر 10 سنين حصل مره، لان احنا قلنا لحد مثلا العيان ده خلاص نوت فور ايفن اندوسكوبي، لان هو كان جي اي بليد وهو كان عيان تيرمينال. فلما في دكتور قال لا، هو اللي كان هو الادميتنج وغير وساعتها اتعمل عليها ام ان ام، يعني ان ازاي ان بعد ما احنا اتفقنا حصل تغيير وبعدين اتفقنا ان هو نفسه عشان هو كان جونيور شويه، هو كونسلتنت بس كان لسه مخلص. عرفنا ان كلمه ان هو كان هو بيقول اصل في حاجه ريفرسبل، انا عاوز اصلح الريفرسبل بعدين يموت بحاجه تانية. قلنا له ما هو في الاخر eventually اي ديث يعني في الاخر هيبتدي يجيله حاجات potentially reversible، بس انت تفكر ان هي reversible، بس انت بتزود السفرنج. يعني دخلته وعملت له اندوسكوبي وحطيته وفي الاي سي يو وخرج منها، وبعدين بات بعدها برضك ب 6 7 ايام تانيين. ف ف فبيحصل ان في ناس تغير بس الفكره ان انت ما دام حطيت حاجه واتفقنا، والعيان كمان، ما لازم احنا مش احنا احنا بنحاول دايما نعمل زي اجريمنت قدر الامكان. قدر الامكان مش عمرنا ما، انا برضك في اخر 10 سنين مثلا، ولا اخر من اول ما ابتديت عمري ما رحت ما سمعت حتى ان حد راح المحكمه عشان يعمل اوردر لحاجه زي كده. الحاجات اللي بتروح المحاكم وكده، اللي فيها طفل مثلا فيجيتيتيف لسنين طويله وسافرنج، والاهل مش عاوزين يشيلوا اللايف سبورت من عليه وحاجات زي كده. ودي حاجات ما بتحصلش كتير. يعني احنا عاوزين نقول ايه، ان على فكره هي لما الموضوع بيتطبق بيبقى الحاجات دي فيري رير. الناس بعد ما تتعود عليها هم نفسهم بيبقوا جايين يقول لهم احنا نجيب لهم الورقه دي، بيبقوا هم عارفينها. فهي طبعا صعب ان انت تبتدي حاجه من الاول، ودايما هيبقى فيه اعتراضات، وفي ناس يقولوا لا ده ممكن يستخدم مثلا ان انت الناس تبقى مهمله ويقول ان خلاص مش هنعالج العيان. طب ما هو اي حد هيعمل حاجه زي كده، ما هو ممكن معرض ان هو المساءله، فهو مش هيعمل كده الا لما يبقى متاكد. فهي الفكره ان يعني احنا 60 70 سنه فاتوا ما كانش في فنتليتور ولا في اي سي يو في مصر ولا في الهند والناس دي كانت بتموت بطريقه طبيعيه، ناتشورال ديث، اللي هو الطريقه الجميله ان الواحد انا نفسي اموت كده، اموت على سريري والناس حواليا و... وده يعني عملته لاهلي هنا. يعني في حمايه مثلا اقول لك حاجه بيرسونال، يعني خلاص كان هو تيرمينال كانسر، وخلاص عارفين ان هو في خلال جبناه وبقينا نطلعه البلكونه يشوف البحر كل يوم ومات في بيتي، مش في بيته عشان يبقى معانا. يعني احنا كنا كده ليه؟ اللي خلانا بعد ما التكنولوجي دي جت غيرنا وبقينا لازم العيان يموت في الاي سي يو ومركب تيوبه وعليه وتعمل له سي بي ار على ان ده هو ده الناتشرال ديث. بس واي حد تاني هو كده ما خدش حقه، العكس هو. ولازم نعرف ان دي حاجات اتوصفت لظروف معينه، الحاجات دي لناس معينه. we should not take this technology and make it like for the whole public to die in ICUs. بالعكس معظم الناس ده، انا دلوقتي البالياتيف كير الاحسن بالياتيف كير هو ان ناخد العيان نروحه البيت ونودي اللي يعملوا له الباليشن في بيته. يعني معظم الناس بيموتوا دلوقتي بنحاول ان يموتوا في بيوتهم في النيرسينج هوم بتاعهم اللي قعدوا فيه سنين. آه والاسلام اظنش ان هو عكس يعني انا مش شايف الاسلام او المسيحيه او اي كلتشر اجينست ان الواحد يموت موته ياخد بين كيلرز وحاجات للسكريشنز وحاجات لحاجات لو في انكشس من حاجه، بحيث ان هو مش هيموتوا الحاجات دي. الحاجات دي الدوسز دي مش بتموت. غير اليوثينيزيا، اليوثينيزيا ده بيروح في يوم معين ياخد حقنه باربيتوريتس كبيره، حقنه مورفين ضخمه، يموت في ساعتها في خلال 3 دقائق. احنا مش بنعمل كده، احنا alleviate السفرنج. natural death good death اللي هو في بيته في مكانه، قرر مين يقابله، قرر ايه الحاجات اللي هيعملها اخر ايامه، ان نساعده في حاجات تانية، ساعات في حاجات فاينانشال هو خلاص عارف يموت هو لسه بيتكلم، انت عاوز ايه، حاجات فاينانشال ممكن عاوز يعملها في الاخر. غير ان ناخده في الاي سي يو ونقول ان هو يبقى موجود ويموت في البرد بتاع الاي سي يو والدوشه والنويز والكلام ده. اتمنى اكون عرفت اجاوب السؤال.
الدكتور علاء فتحي كاتب ملاحظة بيقول shocking session but actually we need to unblind our vision to save at least some of our resources to save indicated patient. وده اللي انت قلته يا دكتور ايمن،
م.
بلاش curative treatment لهوبلess كيس اللي
بالظبط.
يقعد يحط ليفوفاد كمية كبيرة، واحد مالتي اورجان فيلير وعنده سي في اي وعنده مالتي مالجنسي، ما خلاص ليه تحط ليفوفاد؟ خليه العيان هوبفول. فشكرا
مهم.
دكتور علاء على الملحوظة دي. مم. في أي حد
دكتور
يحب
حسن،
يعلق على اللي
يعني
قاله
احنا
دكتور أيمن قبل ما نقفل الجلسة. واضح إنها
دكتور
كانت
حسن دكتور
experience
حسن احنا بنشكر